They will speak.
Neurons, millions and millions of neurons.
First I'll speak. After that, it has to be transferred.
Everything depends on the traffic
okay.
in social compound.
Mine is just introduction.
Traffic is
Prayer and introduction. After that, I think he will.
good,
No,
like
Sanjith is speaking
Metropolitan
first.
Coimbatore Road.
Sanjith will speak.
Things are made more easy nowadays.
Okay.
Bleed, is it a bleed or is it a clot? It's such a million-dollar question always. But now, no. CT scan in Kotagiri is, I have to pinch myself. We have CT scan in Kotagiri. We look forward for a very enlightening, fruitful lectures. We have 3 eminent speakers among us, and the one who jumped into the field and proved himself a lot. Dr. Tony is here with us, and every case I also was following. It's a wonderful job. I request Dr. Tony to start the meeting with a word of prayer and then start with the speeches. Thank you.
This mic means I can talk from here. Huh? How is it? Okay. Okay. So I welcome you all to this gathering. I think after a long time, I'm seeing so many of you again. So thank you so much for coming. And thank you, Dr. Ravi, for such a warm welcome and introduction. So shall we just start with a word of prayer? We'll just pray and we'll start. Heavenly Father, we thank you for this time. We acknowledge your presence in our midst. I pray that you will bless us as we present things about stroke and how to manage these things. Fill us with your wisdom and help us to understand well, and so that we'll be able to translate this into good patient care, that it might benefit the people of this place, that it might glorify you through all that we do. We ask this in Jesus' name. Amen. Okay. Yeah, it's my great pleasure to welcome 2, I would say, eminent speakers. One of them is a good friend of mine. When I was doing my PG, I think he had just finished his DM. And he's a good friend of mine, very approachable. Generally, if you say cardiothoracic surgeon, neurologist, phone pesna edukka maatanga illa they'll, but someone who's very approachable. And when we started the stroke thrombolysis here in KMF, I had a lot of questions and doubts and fears, but Sanjith was always there to, whenever I call him. However, he's the head of the department of CMC Vellore, neurology department. The neurology department itself is bigger than KMF Hospital. Okay, so you can imagine. Sanjith did his MBBS and MD and DM in CMC Vellore, and he's been there since then. He has a special interest in stroke, and he did his after his MD, he went on to do a fellowship in stroke in Calgary in Canada. Am I right? Yes. And since then, he has come back and he started the stroke program in Vellore in a big way. And now there are people who are specialized. Earlier, neurology means every person would do everything. But even in neurology, now there is subspecialization, where some people do only stroke, some people do movement disorders. And under his leadership, the department has grown to what it is right now. And we are very grateful that he's here with us. If at all there is anything that you want to know about neurology or stroke, these are the 2 kinds of people that you need to ask. Okay, so if you have any doubts and questions, please feel free to, at the end of the talk, please feel free to ask questions. Like I was saying, subspecialized under stroke. So we have another person, Dr. Vivek Nambiar. He's a neurologist. He's the head of neurology in AIIMS Kochi. And he was telling me, I'm the only neurologist in India who only does stroke. Okay, and he does stroke not from 9 to 5. He does stroke round the clock. So he has PGs under him. He has fellows under him. So he has one big well-oiled machine that keeps running round the clock. And he had a concern for stroke patients in peripheral hospitals. Okay. Now, a person who is in a big hospital earning enough and, having his own publications, he had the concern for people who come late, to a hospital and, could not be treated optimally. He said we should do something about such patients. And with a lot of hard work and difficulty, he got the Kerala government to sign an MOU where a patient and in a peripheral hospital, when they come to the peripheral hospital within the window period, it may be a junior MBBS doctor, it may be a stroke specialist. They can contact his unit, either him or his people, through internet, through telemedicine, and they will guide them in the stroke management. They call it the stroke, and it's through the ICMR, correct? It's linked to the ICMR.
Initially, it was started or to be positive with the Kerala government. Then we
okay. Yeah. So maybe he'll introduce that also to you. So now it's linked to the ICMR as well. And through Sanjith, I came to know about him, and so we are now linked with this program as well. And in fact, we had the inauguration today only. It is our hope that our stroke management will improve even more through what he does. So thank you. I don't know anything more about him, so maybe he will say something more. And so I invite Dr. Sanjith to start off. So we have we are only talking about stroke with an emphasis on ischemic stroke. Okay. We will also talk a little bit about hemorrhagic stroke and its management. And I will present something about what we have done in the last 1 year in KMF. Thank you. I invite Dr. Sanjith.
Sorry, make it on easy.
This is a pointer here somewhere.
Okay.
We'll come on that.
okay. Just. Mouse will be.
So thank you so much, Tony, for inviting both of us. So in fact, I think both of us did a stroke fellowship in Calgary. I think it was overlapping. So I think I know Vivek from that time. And yeah, so thank you all of you for coming for this evening's talks. So I'll be briefly talking about treatment of acute ischemic strokes. So to understand treatment, we need to understand the pathophysiology. Then only we'll know how to treat any condition best. So first we look at the pathophysiology of a stroke, ischemic stroke. So we should use the term stroke when there is a abnormality to the brain caused by a decrease in this blood supply. Only you should use the term stroke when the symptom starts abruptly. So there can be other conditions which impairs the blood flow slowly. So those conditions are not called strokes. Now we'll see how a stroke will progress in the first few hours. So for normal functioning of the brain, as you know, even though brain is a small organ, it uses the maximum blood per unit in the body. So for normal functioning, you need 50 to 60 ml of blood flowing through 100 grams of brain every minute. So when this decreases, the brain will initially try to conserve energy. By first, it will decrease protein synthesis, then it will stop synaptic communication between the neurons. And if it falls below 10 ml per 100 gram per minute, there will be irreversible brain death. So, and also this blood flow can differ in the gray matter and the white matter, because gray matter is where there are neurons and this uses up more energy than the white matter. So we'll see what happens. So just imagine this is the internal carotid artery, which is going inside the brain and dividing into the middle cerebral artery and the anterior cerebral artery. So we'll see what happens when there is a clot in this one of the branches of the carotid artery, which is a middle cerebral artery. So when there is a block in this artery here, immediately what happens is the blood flow in that adjacent area drastically falls to around 10 ml per 100 grams, which can cause cell death. And this area is called the core, infarct core. Now, if you look at this area here, this area is getting blood supply from this artery which is blocked, as well as this branch which is still patent. So in effect, this area here is only getting 50% of its blood, which is supposed to be getting. So this area has still a good blood flow there, but it is at risk of getting infarcted. So this area is called the penumbra. So in a patient who comes early, we have in the brain two regions. One is the infarct core, which is already dead or about to die. Another region called the penumbra. So another region called the penumbra, which is a larger area, which if you don't do anything, this area can get infarcted and get incorporated into the ischemic core. So now in the initial stages of stroke, this penumbra is maintained by your collaterals. So there are collaterals in the brain which goes from the external carotid artery, and also from the middle cerebral artery there are collaterals which goes from the surface and tries to supply the area called the penumbra. So as I told you, if you don't do anything, the whole area will get infarcted and you will have a very large stroke. And all this happens in a large infarct, in a large vessel occlusion within the first 4 to 6 hours. So within 4 to 6 hours, the story is over. And what is more important is every second counts when a patient is coming to you with an acute stroke, because about 30,000 brain cells are dying per second in the initial 4 to 6 hours. So the whole treatment of ischemic stroke is to save this area called the penumbra. So that is what I'll be talking about. So how you assess a patient? So when a patient comes to you with a stroke, first you need to clinically assess the patient. The first question is it a stroke or something else? Second, if it is a stroke, how severe is a stroke? So suppose somebody is in the emergency ringing up Tony, you can ask how severe is the stroke. We need to have a scale. And third thing is there any intervention possible in that particular patient? These are the three questions all of us should be asking whenever we see a patient with an acute ischemic stroke. So the first question is it a stroke? For this, we have a mnemonic called the B fast. So B stands for balance. So suddenly somebody is losing his balance, and or dizziness. That's the common word patients can use. Second is E stands for eyes. Suddenly is not able to see clearly with one eye, or a part of the visual field he cannot see. That is E. And F stands for face. You ask the patient to say E and see whether there is any drooping from one side. And A for arms. You ask the patient to stretch his arms. And if it is a mild stroke, you might see this one, the side which is weak, going down. S stands for speech. In this, you should do two things. You make sure the patient is able to understand what you're telling him, and also ask him to speak and see whether there is any difficulty in him speaking. And T, the most important thing is time, because your treatment depends on the time of onset of the symptoms. So note the exact time when the patient started having his symptoms. This is called the B fast. Initially, it was called only fast. Now we have added two more things, that is B and E. They're called the B fast. Now, what we should know is there are a lot of other medical conditions which can mimic a stroke. So this can be easily remembered by the mnemonics MEDICS. So M stands for migraine, multiple sclerosis, or even a mass lesion in the brain. Sometimes the patient can have a tumor which can be silent. It can be in an area which is not very eloquent, and suddenly the tumor can have bleeding into the tumor, and the patient can suddenly develop a deficit. and E stands for post-ictal state. So you would have seen patients with seizure. After they have seizure, they can have weakness on that one side of the body, which can even last for up to 1 week sometimes. So the patient or the relatives may not have seen the patient having the seizure. They must have seen only the patient with the post-ictal weakness. So that is E. And also any electrolyte imbalance. It can be hypoglycemia, hyponatremia, hypokalemia. Any electrolyte imbalance can also mimic a stroke. D stands for dissection, aortic dissection, and disc prolapse. So suddenly somebody can have a disc suddenly pressing on a nerve root and he may be unable to lift that hand. And if it is pressing only on the motor root, he may not have any pain. I stands for infection and intoxication. Especially in our country, tuberculous meningitis can present like a stroke. The patient may not give you a history that he has been having mild fever going on for some time. And TB, as you know, can cause endarteritis, which can cause a stroke-like manifestation. C stands for contusion. Especially in the elderly, they can have a subdural hematoma and secondaries. And of course, rarely we can see conversion reaction. The patient must have seen somebody had a stroke, and for some reason he can have a conversion reaction and come like a stroke. So these are all the stroke mimics which should run through your mind whenever you see a patient with an acute stroke. Now the next question is, how severe is the stroke? So what is severe to me may not be severe for somebody else. So we have a uniform scale to measure the stroke severity, and that is called the NIHS score. For those young doctors, you can all of you can get certified in doing this NIHS score online, and you can add it on your CV because you can get yourself certified online. So what is this score? This is a score rating from 0 to 42, which composes of 11 items. So this you can look up. So the higher the score, that means the more severe is the stroke. So normal 0 means there is no deficits and it may not be a stroke. So up to 15, it can be a moderate stroke. Anything above 15, 16 and all, it is a moderate to severe stroke. And more than 21 means it is a very severe stroke. The higher the score, the more severe the stroke on the NIHS scale. The next question is there any acute intervention possible for this particular patient? For this, first we have to do CT or MRI. So without imaging, we cannot treat a patient with a stroke. So there are something called 4 Ps. When you have a patient with stroke, doing imaging, we'll have to look at the 4 Ps of stroke. First is which artery is occluded, that is the pipe. Which pipe is blocked. The second P is how much of the brain is already damaged. That is the core. How much of core is already gone. And next P is how much penumbra is there to be left to be salvaged. And the last P is what you call as peripherals. How this patient's collaterals, whether it is robust or poor collaterals. So these are all the 4 Ps of stroke imaging. But for treating a patient, you may not require all the 4 Ps. Even with 1 P also, you can start treatment. So look at the parenchyma. All you need is a plain CT scan of the brain. And so in the early stages of stroke, your CT will look absolutely normal. If the patient has come to you very early, like say within 1 hour or less than that. But if you are using MRI can pick up very early changes in less than up to within 15 minutes, MRI can pick up changes. But you don't need an MRI to treat a stroke. All you need is a plain CT scan. And there are some signs we can look for if you're doing a plain CT scan. One is what you call as a loss of insular ribbon sign. And you can see this side. If you compare this side and this side, you can see here on the normal side, you can see the sulci and gyri are nicely seen, whereas on this side, it is all ironed out. So that is called ironing out of the sulci and gyri. And of course, there is one sign which is very easy to pick up called the hyperdense MCS sign. This shows that there is a clot sitting in one of the large arteries called the middle cerebral artery. So also, if you are interested, there is a score to see how much of the brain is damaged called the aspects score. Now, which pipe is blocked? So that's the next P. For this, you can use, if you are using MRI, you can use your MR angiogram, or if you're using your CT, you can use what you call as a CT angiogram, where you need to inject a contrast and get special cuts on the CT scan. Next is whether there is a penumbra, there is tissue left to be salvaged. So here we can use lot of modalities. You can use something called diffusion flare mismatch if you are using MRI, or you can use specialized scans like perfusion imaging. But I don't think first of all, we have to use our clinical judgment. So this is a 56-year-old smoker who was woken up with a stroke, and he has right hemiplegia and right-sided neglect. So neglect means he's not bothered about his side which is weak, and he has global aphasia. And this NHS is 16, that means he has a moderate stroke, and this is his scan. So anybody can, any of the juniors working in Mission Hospital can tell whether there is anything wrong with this clinical picture and the scan. So in the scan, you are seeing this area is involved deep in the brain, right? But he has global aphasia. So what does it tell you? If you have to have global aphasia, you have to have cortical involvement. So this patient, there is something called clinical radiological mismatch. So what you're seeing on the scan is not correlating with your clinical finding. That means this patient still, even though you're seeing a small area of infarct, actually this whole area is at risk of, it's not working properly. Okay, so there is a clinical radiological mismatch, and fair enough, he has a M1 cutoff, right? MC has gone, and he has a large penumbra. So most of the time, we can just use our clinical skill to pick up whether there is a penumbra or not. So then last P is collaterals. Again, it is not needed for treatment, but if you are interested, this is what you can do: a triple phase CT angio, where you can look at the collaterals in the surface of the brain. Okay, now coming to the treatment. So as I told you, it's very, very important that we should be up and running when a patient comes with an acute stroke, because if you have to give IV thrombolysis, you have to do it within the first 4.5 hours. Okay, so that is most important. And in certain centers, we can even prolong it by doing specialized scans, but for all practical purpose, it is 4.5 hours window. So what the definitive treatment is to open up the blocked artery and restore the blood flow. And at the same time, we have to make sure that the blood which is flowing through this artery and the collaterals are maintained. Okay, so these are the two things which has to be done as soon as the patient comes. And there are some neuroprotective agents which is not of any use up to now from the literature. So the first thing is to maintain the collateral flow. Even before you think of thrombolysis, make sure that whatever blood is reaching the penumbra is flowing properly. For this, the most important thing is never reduce your blood pressure in a patient with an acute ischemic stroke, and this can be disaster for the patient. So these are the numbers all of us should be knowing. If you are planning to give IV thrombolysis, anything up to 185 is fine. We don't need to bother. 185 by 110. So that is the BP we should be targeting. Up to 185 by 110 is fine. No need to give anything. If you are not planning to thrombolyze, suppose a patient has come to you 8 hours or 12 hours, you're not, anyway, he's out of the window 4.5 hours. If you're not planning to do anything, a systolic BP up to 220 is fine. And a diastolic BP of 120 is fine in the first 24 hours. So never reduce the blood pressure in a patient with acute ischemic stroke. But there are some exceptions to this. One, if the patient has an associated coronary artery disease or event, the patient has an MI and a stroke together, or the patient is in heart failure, or you are suspecting a aortic dissection, or the patient is in preeclampsia or eclampsia. These are the only indications where in a setting of a acute ischemic stroke, we have to reduce the blood pressure. Otherwise, never reduce blood pressure abruptly. So this is very important. So what we can do to reduce the BP is to give short-acting medications like IV labetalol, and it can be repeated till you can achieve your desired target. And if the patient is already taking some medications for blood pressure, you can start it after 24 hours. The first 24 hours, you did not start the medication, and that too, even after 24 hours, you have to reduce it very gradually, 15 to 25% in the first 24 hours, and then maintain a BP. So the next step is to recanalize the blocked artery. For this, we can use two agents. One is called tenecteplase, which also is used for MI, and also you can use actylase, that is tissue thromboplasminogen activator. So right now, most people are using tenecteplase because this is cheaper. Not only cheaper, it's a single injection. You just need to give one injection and that's it. Whereas if you are using this alteplase, you have to give a bolus, and then the remaining injection you have to use an infusion pump and give it over the next 1 hour. So these are the two agents we can use for recanalizing the blocked vessel. Another important thing is, even though I told you that these drugs has to be given within the first 4.5 hours, if you look at this graph, you will see even within the 4.5 hours, if you delay, the effect is going to be less. So the patient comes at 1 hour, so you can't say, oh, I have another 3.5 hours, I can go slow. No. So if you look at this, this is something called number needed to treat. That means, suppose you are treating 10 patients, how many of them are going to benefit? So number needed to treat is how many patients you need to treat to get benefit for one patient. So if you look at this, it's a patient, if you are giving this drug within the first 90 minutes, out of every 4.5 patients you are giving, one patient is definitely going to benefit. So as you go down the window, your number needed to treat is also increasing. So even within the window period, you should be fast and do the thrombolysis as early as possible. Another important thing is the site of occlusion. So that's what I told you. The first P is the pipe, which artery is blocked. This is very important because if you look at this diagram, if you have a blocked artery here, which is at the terminal distal end, the chance of your IV thrombolysis opening up that vessel is almost 73%. But as you come down more proximally, if you have a occlusion here, then it is reduced to 40%. And then if you have a occlusion here, your chance of your IV alone opening up is only 14%. So it depends on the vessel which is occluded, the efficacy of your drug is going to be different. So that is when you have to use mechanical thrombectomy. That is, you have to go into the artery which is blocked and pull out the thrombus or clot which is sticking there. That Dr. Vivek will be giving you a detailed talk on that. So I'll just skip these slides. And then also there are a lot of this neuroprotective agents in the market. You would have heard about citicoline, edaravone, and all these things, but none of them have been shown to have any benefit in the treatment of acute ischemic stroke, and that is waste of money. Okay. Also, sometimes you can have a patient presenting like this. So you have a large infarct here. Patient has come to you after 16 hours. They have been keeping him in the house thinking that he'll improve. He has been brought after 16 hours. Nothing can be done here. So what you can do is you can start your anti-edema measures because there is the brain is under high pressure. But after 24 hours, sometimes it can increase. You can have higher ICP going up. Then patient might require a decompressive surgery to save his life. So that is so up to 10% of all ischemic stroke can present like this, which can be life-threatening. and might require surgery for saving the patient's life. This is not going to improve the weakness, but only for saving the life. Right. Okay. So if you, after treating the patient, then successfully, or even otherwise, even if the patient comes to you late, you have to do what you call a secondary prevention to prevent the next stroke from happening. Why? Because if a patient gets a stroke, there is a up to 20% chance that he'll be going to have another stroke in the next 1 year. Okay, so we have to take adequate measures to prevent the second stroke. So for this, we have to find out the etiology of the stroke, what caused the ischemic stroke. So we have a classification for this, which is commonly used, called the TOAST classification. So these are the subheadings under this classification. You can have a large vessel disease. You can have a patient who has a carotid disease, which has caused a stroke. A clot would have broken and gone and occluded an artery upstairs. Or you can have a small vessel disease causing a stroke. Earlier, it was called lacunar infarcts. And then you can have a cardioembolic stroke. The patient can have a atrial fibrillation, and suddenly the clot can go from the heart into the brain and cause a stroke. Also, there can be other etiologies like, say, SLE, where you can have antiphospholipid antibody causing a stroke, etc. And there can be other undetermined. Sometimes you can do whatever investigations you want, you may not find a cause for the stroke. So you have to know what is the cause for that stroke in that particular patient to give him adequate and secondary preventive measures. So first of all, antiplatelet agents. If it is a small vessel disease or a lacunar infarct, we just need to use single antiplatelet agents. It is a large artery stroke, like a M1 or a basilar, then we have to use double antiplatelet agents, 2 antiplatelet agents, at least for the first 3 months. Suppose a patient has come with a atrial fibrillation, patient had a stroke, and on the ECG you're seeing atrial fibrillation, then there is no role for giving antiplatelet agent. You have to give him oral anticoagulants, either warfarin, or now we have newer oral anticoagulation like dabigatran, apixaban, or rivaroxaban. Also, rarely, if you have a carotid disease where there is a thrombus, you can demonstrate there is a thrombus which is floating. Again, we might use anticoagulation at least for the first few months and then switch over to antiplatelet agents. Lastly, coming to carotid disease, sometimes you can have a patient who had, you evaluated him after the acute phase, you found that there is a carotid artery stenosis. So you have to be very careful here. Don't send everybody for surgery or stenting, which is now commonly happening, and patients are having problems after that. Only if it is the same site which is showing more than 70% stenosis or occlusion of the carotid artery, is it worth doing your carotid endarterectomy or stenting. And it has to be done as early as possible within first 2 weeks. So otherwise there is no benefit for these patients. So I would like to conclude by saying that, like, when you hear heart attack, everybody is like in panic because attack. So now the World Stroke Organization, in fact, is trying to change the name from stroke to brain attack. So patients are, the health care workers are more like up and about when you have a patient with a brain attack. Thank you. I think you want to have the questions now or in the end?
If you have any questions to ask, please. It's a good time to ask.
Or we can have in the end. It'll be.
We can have at the end also.
I think after, because Vivek might also talk on something, so we can have everything, all the question answer together.
Sure. Thank you.
Thanks.
I invite Dr. Vivek to continue the talk. I think maybe I can emphasize that two important things, at least from what I understand, is one, from a clinical point, don't reduce the BP abruptly. I think that is the most important. At least for the first 24 hours, BP of 200, no problem. I was keeping 200 as my Today I came to know that even up to 220 is okay.
So 220 if you are not thrombolizing.
Yeah, if you are not thrombolizing. If you are thrombolizing, 180. Try to bring it below 180. Yeah. But yeah, so I think that itself will save lives, because it's the same with head injuries also. When you have head injuries also with because I'm a neurosurgeon, they also need the BP to be high for whatever blood flow to keep the brain alive. So even in head injuries, don't bring down the BP abruptly. Thank you.
Why no calcium channel blockers?
Yeah, so one thing we should never do is to give sublingual nifedipine. That's the worst thing we can do it in any patient. But later on, after the first day, if the patient is on some calcium channel blocker, oral tablet form, you can start using. No problem. But no sublingual nifedipine. That's the worst thing. It suddenly decreases the BP.
During my internship, we were told, please give sublingual
Yes.
nifedipine. We used to poke the nifedipine soft capsule and put it under that tablet. But then that's not good.
A very good evening to all, and thank you, Dr. Tony and Dr. Sanjith, for this opportunity. I think you are all very lucky to have Dr. Tony here. I've never seen such a neurosurgeon who's so active in stroke management. It is wonderful to see the very active stroke unit here, and the meticulousness with which he does the cases, and the documentation which we usually will not expect in a hospital, peripheral hospital. Usually people will do thrombolysis, they actually sit at home, give the phone to the RMO there and ask to give thrombolysis and sleep at home. But I was surprised to see Dr. Tony very meticulously seeing the patient and the scan and sitting there only for thrombolysis. Today, after the inauguration, we have the first thrombolysis done. I have to congratulate Dr. Tony, and that is a patient has improved very well. Thank you. So actually, Dr. Sanjith, thank you for explaining all the aspects of stroke. So actually, stroke is always neurologist and the physician and the cardiologist. There is a sort of competition in management. We were always envy of cardiologists. I wanted to be a cardiologist in my career, but unfortunately, I wrote all the entrances. I get some lower ranks or some interviews I lost. So why the reason was, after surgeon, I felt cardiologist was doing a great job, because patient comes with chest pain. You do something and patient is okay. Patient is going home day after tomorrow or after 2 days. That is very inspiring to see. So we were always teased by our colleagues, cardiology colleagues and nephrology colleagues. And so what you do, you give aspirin, you give neurobion. इतना तो करना है ना भाई, क्या करता है तू? So everybody used to ask, like, okay, but that was always a pinch in the heart. Like, being a neurologist, you don't do anything. But for your information, now neurology is the most expanding field in the world. We have treatment for so many illnesses. We have in neuroimmunology is a field which is developing very much, and there are treatment for so many smaller things which you think there is no treatment. And there are so much neuroimmunological syndromes which you would think these are all normal for aging, or some delirium, some mild dementia, all those things we used to underestimate. All those things are having good treatment now. That means even we are doing a lot of research work in this field. So for stroke, it was always neurologists. There were good neurologists across the world. They were trying to push the management of stroke. Okay, cardiologists are opening the vessel. Why can't we open the vessels? So actually they were trying to give, because as you know, the thrombolysis for MI started like way back in 1984 with the streptokinase. So that time only some of our colleagues were trying to give streptokinase for stroke. So they have given streptokinase, and many patients develop bleed. Because while doing MD, we have seen, because we also thrombolyze a lot of MI patients with thrombolysis. That time what happened, and 1 or 2 of them will die, because after thrombolysis, ECG will be flat, good, and the ST elevation will come down, but patient is not speaking. So that time we do a CT, big hemorrhage. Okay, we'll talk to the family that this has happened. So this was the thing. So, but the first trial for thrombolysis was streptokinase with heparin and heparin alone. that is published in Lancet. That is a negative trial. So that caused the whole hope of thrombolysis in stroke. But luckily, we got the new drugs like the tissue specific, because they were modifying the streptokinase, which is actually a animal or the non-human molecule, because it is from the streptococcus, no? So we got human-specific molecule, which is the alteplase, which is actually a serine protease in the body. So it is there. The alteplase is there in the body of everybody, in the endothelium. It's a serine protease. So they have made it by recombinant technology and developed it so that when it was given, it is more specific to human fibrin. So the fibrinolysis was happening. So that is how the alteplase came. And then the German group, they were really pushy. Can you imagine? They were doing a trial in 1993. Within 2 years, they have completed 636 patients. Within 3 hours, patient comes from home to the hospital. Like I was much impressed by Dr. Tony's, he will present now, but I'm not, I think I can mention something about what he's going to present with his permission. The mean time to hospital is very less in Kotagiri. That is very surprising. For us, it is like 5 hours, 10 hours. We hardly see few patients only coming in window, but here you have very good awareness and people are coming in. Like median time was 2 hours. Sanjith, 2 hours. Less than 2 hours. That is very good. So actually, when these German guys have completed the trial, patients from stroke at onset in the home coming to the emergency, you do the CT scan, rule out a bleed, and you thrombolize in a trial after permission or consent for randomized trial. And they have enrolled 636 patients in a span of 2.5 years. Very commendable work. So that became a positive trial called NINS trial. And that trial was positive. That is the base of we are doing all this talk and giving thrombolysis. So after thrombolysis, what next? So again, that time only, when 1996, the trial got completed, and it came as a recommendation. So, okay, you can thrombolyze the patients in 3 hours of time. So that came from AHA. So people started thrombolizing. Then some of the nervous neurologists, they want to do some intervention. The cardio, why can't we give this drug into the artery? Anyway, you are giving the drug IV and that is causing some side effect. Why can't you give it, take a tube or pipe or catheter, whatever, give the drug there only on the clot. So they were trying from that time only. They have done the first trial where within 4.5 to 5 hours, people with a stroke, they were given thrombolysis and they were also given this drug through the catheter, through the femoral artery. They have taken the catheter all the way up and started giving this drug called pro-urokinase. So that urokinase came and pro-urokinase. That is called PROACT trial. That is a good trial. But unfortunately, what happened to that, we do not know. The drug stopped from the market, maybe because of industry interest or whatever. So sometimes it will happen. Industry will kill certain molecules which are not very profitable. So somehow it happened that drug did not come out. Then there was a big vacuum. There is because that is a negative trial. That is a positive trial. The second trials were negative. So there is big vacuum from 1996 up to 2013. It's a big gap of without any progress in the acute stroke treatment. So luckily, so we got, this is the evolution of these things. The aim is a work of a plumber. You can see that. So we have, it's a little bit not. So somehow you remove the clot. Somehow you remove the clot. The first row, I'm not able to see that. Can you? So that light, so that.
It's getting cut off.
No, we cannot see the marker. Yep. So, yep. So okay. Thank you. Okay. Okay, fine. Okay. So this is what they were trying to do, the job of a plumber. If there is a block, remove the block. That is a principle. So you can see many instruments which they used, and they tried. We have to, 2003 they were using this ultrasonic things to remove the clot. You put a small ultrasound probe and vibrate, that clot will get removed. That is the one thing. Then they tried with something like you want to take something there, you want to take it out. So they were using this device called Mercy device that is in the shape of a hook. And, there is some cork coiling here and there is a hook. You get into the clot and try to take it out. Then they were using something net like this to hold it. And then they were using the suction catheters, small suction catheters along with ultrasound. So now But these were not making exactly big achievements due to several reasons. Sometimes they are getting patients very late. Already the patient is infarcted. There is nothing to do. So they did not work. So later they came with this thing. This is an incidental recovery, the stent retriever. So actually one guy was in Germany was doing coiling, an aneurysm coiling. So when there is a big aneurysm, the mouth of the aneurysm will be big. So you have to put coil in that. But if the mouth of the aneurysm is big, no, the coil will come down. If you putting something there in a, so usually it will be a balloon-like thing and a small mouth. So you can put coil into that. But when the mouth is big, no, you have to need something to support. So they used to do something called stent-assisted coil. They put a stent and put coil inside, then they take out the stent. That is the reason. So he was doing that procedure, and in between, patient had a stroke. Basilar artery got occluded. So he was stuck. What to do now? So some coils are put. So what he has done, he has pushed the stent up to the basilar artery and got into the clot. The stent is already there. He pushed the stent up and somehow he pulled it out. That clot came out. Patient became conscious. Patient was on table, basilar occlusion. Patient became unconscious. So he became panic. So naturally what to do, intra-arterial thrombolysis. So he tried with that thrombolysis. So that came out. That became a big technology. Stent retrieval. So thereafter people started doing, the case report was written. So everybody was thinking that this is interesting. So we can try this. So there was a report from UK, from US. So this became a big trend. And this is called our now current technology called stent retrieval technology. Because nowadays, usually stents are used to deploy there. Okay, you put a stent. Everybody says there's a 3 stent, 4 stent in Kerala, in Tiruvallur. People say, okay, doctor, I am having 5 stents. You'll come like a VIP. He put a key, BMW key on the table. Doctor, I had 4 stents. Okay, thank you. So that's what, I don't know. They think it's a matter of pride. I see Dr. Manyuran and I had 5 stents. Okay. So that's a matter of pride. So like that. So this is, but these stents are not being deployed usually. These are retrievable stents. You put the stent inside the clot, withdraw it along with the clot, and it is done. So you are not deploying it. So that is what we use the technology now. And there are several modifications of the technology to take the clot out. I think all the pathophysiological things have been explained by Dr. Sanjith in this. That is very good. So this is just not any trial talk. Just I know I want to avoid trials, but the removing of the clot in a large artery in acute stroke within 6 to 8 hours of time is a standard of care. So why I would stress this point is we are liable to legal complications if you do not do this. If you do not refer the patient with a apparently large stroke and there is a large artery occlusion, and if you do not refer, if the patient is educated and they know that some relatives say, some nurse in the US say that this is done or not, we may be in trouble. So we have to refer for thrombectomy and thrombolysis. So that's why I said there is strong evidence. There are several trials which came to be positive, and it is proved beyond doubt that using stent retrieval or removing the clot by aspiration is a proven method, and it really benefits people. Why I would say, so there is something called number needed to treat. So you give one medicine to 100 people, the benefit is for 10 people. So that is number needed to treat is about 100. So if you give the medicine for 3, number needed to treat 3 means you need only few number of patients for benefit. So you are giving aspirin for stroke prevention. You need to give aspirin for 25 patients for really the stroke prevention. So the number needed to treat for thrombectomy is 2.8 within 6 hours. That's a very, very good number. No other measure has got this best number to treat. That means you need to treat only 2 to 2.5 people to get best outcome in thrombectomy in good candidates in 6 hours. So that is why it's a standard of care. We are not supposed to miss the reference. We can get into legal trouble. So there is a class 1 recommendation. So that's a class 1 recommendation, which means you have to follow that. Otherwise, we are legally liable in the US. So this is what thank you, Sanjith, for demonstrating all the angiograms and all. This is the one thing which we are not supposed to. When there's a large vessel occlusion stroke, especially MCA M1 occlusion. For example, this is right metacerebral artery. This is occluded, and this area you cannot see any vessel here. So this area is little bit black. So this area you are seeing the M1 right well here. You can see the perfusion. The perfusion is seen as a contrast. A little bit of white things are here. So that means this area is perfused, and this area you are not seeing above the near the occlusion. We are not seeing any of the vessels. So basically there is an occlusion. So M1 occlusion, and sometimes you can see IC occlusion. Same thing, IC will be occluded. That is also dangerous stroke. We have to go for thrombectomy. So this is, I don't know, this is coming only. I'm going to take this to the side. No. Okay, anyway. So this is very important. This basilar occlusion CT is very important. We have several sad stories where basilar occlusion will be missed because at the GP level, at the physician level, and the patient will be in a very bad tragedy. Because, so this CT scan is showing the mostly usual, we have discussed about the be fast symptoms, arm, leg, speech and all. But sometimes young people, for example, recently I have one patient, 2-3 years ago, one boy who was a son of a very well-placed parents, single son doing architecture engineering in the Madras. He came to Kochi for his holiday. He had food in some fancy restaurants with his friends, in the local friends. And thereafter he came back home, he had started vomiting. So everybody thought it was a food poisoning. Immediately they went to the hospital because he was feeling tired and all. They got admitted in the emergency. He was given IV fluids, Emiset, everything. And the sodium was slightly low. So he got admitted to the medical ward. So initially he was a little bit drowsy. Everybody thought hyponatremia. But, you know, the CT scan was something like this, initial CT. Initial CT was taken and CT was normal, except for that small dot. That is very important sign. That is called basilar dot sign. That indicates the basilar artery is blocked, which means patient is getting slowly drowsy. This mother is asking that duty doctor why he is not, he's very drowsy, he's not moving, what is happening? They told, don't worry, it is sodium, it will be getting better after, and also there will be some toxemia or food poisoning. Next day, patient is not at all moving any limbs. So mother got terrified. She made a big shout and all. Then they asked for, neurologist was called in, and he told there are certain brainstem signs. And then they referred the patient. He came to me. We have done the MRI, whole brainstem. Most of the brainstem is infarcted. And the boy got locked in. So we cannot do anything because it's more than 24 hours. So that boy now is just like completely locked in, but he communicates with that. There is a Stephen Hawking, no? The Stephen Hawking communication is there. Like that eye movements will be picked and he can, so even now, he comes to me for review and he is in a wheelchair. He comes and he talks that machine will say, I want to sue the doctor who has made me like this. I want to write my exam. I want to have my life. All these terrific messages we can see. We feel very sorry for him. So that's what this slide is important for. You can see the basilar occlusion. There's a small dot in the middle. And in the angiogram, you can see the top of the basilar is, here is the top of the basilar. So basilar artery here. Anterior inferior cerebellar artery, this is the posterior cerebral. You can see a black area here, which is the top of the basilar artery clot. Just one thrombolysis, just tenectase or whatever, one injection could have saved this boy at the time, because they came to hospital within like 1 hour. Poor parents, they left their job, they are in Vellore for some time therapy, or they are dedicating their life to that boy now. They resigned from their post, both of them. So these are things which we never forget. This is very important. Whenever somebody comes with acute altered sensorium, especially young people, always think about basilar stroke. That is a very, very important thing. Okay, so in this situation, thrombolysis good. I think this patient will be improved by thrombolysis alone. If needed, we can go for thrombectomy. So this is the same thing. This is the boy's same thing. This is a CT which we have taken once. The same boy's story. This is you can see the black area here, which is totally infarcted brainstem and many of the areas of the brainstem and both posterior cerebral artery territory. So this is just, these are the all different trials. Yeah, I don't want to get into trials and all, but these are all different trials. Escape, myself and Sanjith were also part of it in Escape trial, which is NEGM trial, which has given a very good. You can see the number needed to treat. So this, if you treat. To get one excellent outcome, you have to treat only 4 patients, 6 patients, 4 patients, 3 patients, 2.6 patients and all. So because that means this treatment is very, very effective if it is given in the right patient. That's what something you have to remember. So there are certain candidates where we can do thrombectomy beyond 6 hours up to 24 hours. So these are patients Dr. Sanjith has shown, no? When there is a small, so when patient is having a right hemiplegia and CT scan is normal at 6 hours. So we were talking about 3 hours, 3.5 hours. Suppose the patient is having a hemiplegia, CT scan is not showing anything. So that means this patient is a very good patient with good collaterals. That means the brain is not fully dead, but the electrical dysfunction has happened. So Dr. Sanjith was showing the slide, no, electrical dysfunction. When blood supply comes down to 20, up to 20 to 30 or 20 to 40, the brain will not function electrically. It will stop functioning electrically, but not dead completely. So those patients, we can do thrombectomy even after 6 hours, maybe up to 24 hours. For that, we have to identify those patients. That is a challenge. So it could be CT scan, it could be a CT scan, or it could be a perfusion scan, or it will be our clinical skills. The clinical skills Dr. Sanjith was telling, now one patient with MRI small area, patient fully bad. That means that area is not electrically functioning, but that area is not fully damaged. That is penumbra. There we can do thrombectomy. So there are certain patients whom we can do thrombectomy beyond 6 hours up to 24 hours. So that is what these trials, DAWN trials, are showing. So, but I don't think we have to go too much into that, because any patient who is having stroke within 24 hours is to be referred to a stroke unit or a neurology center where they can do further evaluation. That's what I mean to say. So this is just emergency to cath lab. So we are actually neurologists. We are all knee hammer guys. As per neurosurgeon, we are, we don't do much about it. So luckily we are getting some place to work. Now, like this is from emergency to the cath lab. So we make a puncture in the femoral artery. So from the puncture, because the issue here, why I show this slide is when we do thrombectomy, you have already given thrombolysis. So we do thrombolysis for all the patient within 4.5 hours, the window of thrombolysis, then we take straight away to thrombectomy. So naturally the anticoagulation is going on, no? So there is a high chance of bleeding. So while getting the patient to cath lab, we should be careful in puncture, because if you do the wrong puncture, immediately there will be big swelling, because already the fibrinolytic drug is in the system. So we should be very careful. So this is a careful anterior puncture. So we will not do cross puncture. That means sometimes you give lot of puncture and the blood will gush out and then take that. That is not very welcome in this situation, because patient is already on a drug which is actually lysing the clot. So the bleeding chance is high. So we should be careful. So we carefully look at the location, anterior superior, and then go. And or we can have an ultrasound guided puncture, or we used to do blind puncture, because ultrasound will not be ready by that time, or the time is being lost. So we used to do blind puncture. That's a slightly risky thing, but however, the more you do, will be more good in that. So these are the small things. They put a sheath first. So we want an access to the artery. We put a sheath first. This will allow only the things to go inside, not outside. So this is a valve, and so this is a sheath which will put the sheath, and then this is the whole setup. Actually, this is the puncture site. So from here we put a guide. There will be a sheath here, and through the sheath we have bigger catheter, 8-inch big catheter called guide catheter. Then we have the large catheter for aspiration, and through that there will be a micro catheter and there will be a micro wire. This is a whole assembly of thrombectomy. So through the femoral artery, we can put all those things, so that the issue is here. So we are manipulating from this end through several tubes. So basically, when the artery is very tortuous, we will lose our capacity to torque. If you torque the wire, the torque will not be reaching that end. That will be lost in the bend, because you torque it, that will go to the bend, and the force will be much less at the top. That is one of the issue. So because we are using so much, but however, with means more and more cases we do. So this is a set of thrombectomy which we used to do. So this is for every tube you insert, there is a chance of clot inside the tube. So every time you need a flush saline with heparin going on the side of the tube. This is the infusion for thrombectomy to be correct. So these are the techniques. So what we'll do, we will take the tube here, and then this is the guide catheter. This is the aspiration catheter. you go to the M1, this is a mid-cerebral artery, you go here and do the maximum suction so that the whole thing will come out. So that for that what we would use to know, because when the blood is going in this direction and you do apply suction, it may not completely coming out. So one thing we can do, we can have a sheath, a balloon here. So we'll inflate the balloon at the time of suction so that there will be no forward flow, so that the clot will not move up. So this is called balloon guide catheter, which is, this has got an advantage of blocking the anterior flow while doing the suction. So the whole thing will come out with suction. So that is what we mean. And also the suction catheters, as you know, when you take blood with a butterfly, in a way it collapses. No, when you suck on 10 cc syringe butterfly, you try to take the blood, it will completely collapse. So like that, if you do suction, more suction with the smaller catheters, no, it will collapse. So we need braided catheters. So it will be metal ring in this, so that it will not collapse, even though give good suction there. So several, we were showing the several stent retrievers we use, like this is the ordinary one. Then we have something we can introduce in the clot, it will be trapped inside the embo trap, preset. All these are technical modification, and different companies coming with small modifications. Nothing much important here. So like there is something, they'll have a closed end here. We deploy into the clot, and then the clot cannot go out because it is closed here. So many materials are there. So there so many aspiration catheters. These are all smaller thing, very soft. The thing is, they have to be going through the arteries very freely. For that, we need better material comfort, and also they are making so many. Because this is what we use is an excellent one, Cat 6. So this is called Catalyst 6 catheter. This will go without wire, it will go. It is a very smooth one. So technologically, we are getting better and better to produce better outcome in thrombectomy. So this is a suction device. Sometimes we use hand suction. So 60 cc syringe, you keep the tip of the catheter on the clot in the fluoro, and you just aspirate with a 60 cc syringe, it will come out. That is one thing. Other thing, we can have suction machine. So you switch on the suction machine. So we will wait for some time, every clot will come out. So that's very simple actually. The procedure is very simple. Only thing we have to reach at that point, that's all. So the different techniques, like we can use both suction, and stent together. That will improve. That is called Solumbra technique. So different thing. Only suction, only stent retriever, suction with stent retriever, depending upon the difficulty to take the clot out. So all these are things. So this is one of the case. I think our video will play. So this is a simple case, which is actually a right MC occlusion, left hemiplegia, young male with rheumatic heart disease and a clot. So we can see this is the angio. There is a clear-cut occlusion here. So there's a clear-cut occlusion. This is the anterior cerebral artery, internal carotid artery, right midcerebral artery. You can see the anterior temporal branch, which is open, but the distal part of the M1 is blocked. So there is an acute embolic occlusion. There is an embolus has gone from the heart to that area. So this is the initial shoot, and so this is what we do. Like just so you can see that there is we are taking that here. You can see the tip of the catheter. This is occlusion, and you can see this tip of that suction catheter there. And after a single suction, very simple. After single suction, you can see this shoot is completely opened up. So this is what we do. So this is a very straightforward case. There is no good anatomy, young male, but sometimes it is not as easy as we see in the movie. It will be very difficult because to reach there will be a lot of tortuosity. There will be problem in the aortic arch. All those things will be there. So this is another case where, so this is a little bit slightly difficult case because of some tortuosity. We can see there's one branch open here and other branch is closed. So that branch is open with another catalyst 6 suction. So this is the other branch is open. Sometimes we get branch occlusions. So sometimes there will be challenge. The carotid already will be blocked, or 90%. This patient will develop a stroke. So we cannot see anything above. From here, everything is lost. So it will be difficult to go. So those situations, what we'll do, we will try to go with the neck, and we bombard the neck and go up, get to that artery, and then you take the whole thing out, and then we do carotid artery stenting, because sometimes we may have to do that. So this is another patient. So this is a different catheter. You can see the end of the stent in the left midcerebral artery. This is the wire. This is a big tube, that is suction catheter, and you can see the stent here. So this is a Solumbra technique that opened reasonably well. You can see that artery was not here. So using the suction, we can open it very well. So sometimes this will happen. That means there is an M1 occlusion here. So this is the left ICA. We can see the midcerebral artery is occluded. This gives a clue that this artery is previously diseased. It is not a clot going from heart to the brain. It is already diseased artery, bad artery. So we try to go here, and we went with the stent retrieval here. You can the stent retrieved, and there was some opening. Okay, this is opening. We thought it was great. We are very good and all. We thought about closing the case because there is some stenosis. We don't want to do angioplasty and stenting here because it is slightly risky. So we thought we will leave. So we found it is okay. This is okay when you leave it. So after half an hour, patient again weak, not talking. So see, it is completely closed again. It recoiled. So some of the stenosis in the MCA you open for 5 minutes, then it will again close. So we sometimes do several times to avoid stenting, but sometimes it is not possible at all. So here we can see this is, we have to put a stent. This is a coronary stent called Onyx. It's a drug-eluting stent, Onyx. You can see the artery open very well. So sometimes stenting is required, but not every time in acute stroke. We will be careful because if you do put a stent in the brain in the acute stroke phase, you have to give a lot of antiplatelets. So that is very dangerous. So there can be a bleed also. So that is why we try to avoid stenting. So this is what I say, basilar occlusion. I have told you the story of the boy, no? So similar patient, top of the basilar occlusion here. And you can see that angiogram showing this occlusion. Small suction, everything opened. The patient has only right pontine infarct, and patient had mild hemiparesis, which improved. So patient was walking at the end of about physiotherapy, but there is no other deficit. Some mild spasticity on them. So that is, so if you don't do this, this patient will die, or patient will be locked in, just like the boy I have told. So that's the importance of doing this. So if it comes within very early window, we can actually thrombolize the patient also. That is why Dr. Tony is doing a great service. Suppose the patient comes to Kotagiri, do the CT, do thrombolysis, done. Today we have thrombolized in like less than 40 minutes. Actually, the current door to needle time is less than standard American Heart Association. That is about 45 to 1 hour. We have thrombolized the patient today by like maybe half an hour. So that's a quite good thing. So I don't want to prolong it. I mean, is it long too much? Like, so these are all like some difficult cases and all, like where we have to do so many. This is another device, multiple stents and all. So there can be sometimes access issues. Sometimes we do radial thrombectomy. Radial thrombectomy is good for very bad arches. So even though we show the pictures very beautifully, it will be very difficult to do. Sometimes artery, the catheter will not go. All those things can happen. So sometimes you have to take radial artery also instead of femoral artery. So sometimes the other issue is we have punctured the artery. Now we have to close it. That is another issue because there are arterial puncture and thrombolysis everything. So it's always better to have a closing device. We try to do with the closing device also. So these are different techniques and all. So sometimes we have to do stenting of the carotid also during the procedure. So I think it is a good thing, but it's not always easy. There are challenges, there are complications. But however, despite all those things, for a good number of patients, we can give good results with thrombectomy. So this complication, can this happen to us? So we try to go for an M1 occlusion here. So actually the artery got completely dissected and you can see this thing. This was a good artery. We have created this complication. Actually this artery was good, no, before going. After going, artery become like this. This is our fault only. Because the catheter was a second use catheter. That patient was poor. So we used reused catheter. That will be harsh. Whenever you use old materials, the polish will go. The Teflon coat will go and it will be harsh. It will hit the artery badly. It will go for severe spasm. So later we have done, after doing a good angioplasty, we have circumvented this dissection, but these complications can happen. And some of the thing which can happen is vessel perforation, last thing to happen. You will go with a wire in a patient who has been thrombolized. So if something happened, patient moving the head and all, something happen, always anesthesia may not be there. So vessel will perforate. So that can create a hematoma like this. So this is actually what happened, that the wire went to a small branch and perforated. So these things can happen. I'm not presenting the only rosy picture, but overall it is good. That's what I would like to say. Yeah, so these are contrast allergy, vasospasm, vessel perforation, dissection, and all those things can happen in thrombectomy. Yeah, sometimes it will be, this is something which we do repeat CT, there will be a lot of contrast. It will be looking like a bleed, but not bleed actually, that will be contrast only. We have to look at the patient clinically. If the clinically patient is much better, CT showing a white shadow, don't worry, that will be only contrast after intervention. So I think these are one of the cases like carotid artery stenting during the procedure. So in conclusion, mechanical thrombectomy is an effective strategy for large vessel occlusion, and we have to decide clinically whether the patient is affordable, transportable, or doable patient. All those things is an individual decision by the treating doctor. So, it's an ever progressing field. We are getting better technology, better tubes, better wire, better technology, everything. So it is improving. So it could be better in the coming days. And okay, we can reduce the complications of mechanical thrombectomy by proper planning and choosing the correct patient. Thank you.
Thank you. Any questions to be asked before we go to the next talk? This one question, I've asked this question to earlier. What is the cost?
Yeah, I mean, a cost depends upon center to center. Actually, what we do, like if there is an insurance patient, we use all new materials, because here the thing is there is new material and old material. Is it YouTube? Is it? Can you switch off it? I'm not supposed to talk like that. No. It is, somebody can. Yeah. So basically, if it is old materials, you can reduce the cost about 75,000 to 1 lakh. That will happen when you get lot of patients. Your inventory of the instruments will be more. So a poor patient, what we used to do, for poor patients, we'll keep this thing prepared. Once used aspiration catheter. Which
You're talking about sealing it back.
selling?
Sealing.
After finishing, how do you seal the artery?
Oh, for radial artery, as usual, only.
No, you showed a procedure.
Yes, that is actually a good one, because we are giving thrombolytic drug now. So the patient will be having a bleeding tendency. So suppose Dr. Tony is thrombolizing a patient and you are referring to Matthew Cherian sir for thrombectomy, they'll be doing on a patient who has got a tendency to bleed. So once they remove that thing, you have to hold it for 1 hour, 2 hours. Otherwise, the bleeding will not stop.
So you open the field and it's
It's only, we will close, it's only a small puncture only, no? Oh, so
Sealing.
sealing is just pressing only, nothing much. You just press for 20 minutes, it will stop. But thrombolyzed patients and high BP patients, it will not stop. There you want some occlusion device. There is a device, Obtura and all.
Yeah.
You inject it and then the stitch will happen. You pull it, it will be stitched. The artery will be stitched. So that is called closing device. That is very good. That is standard. And abroad it is standard, but it is maybe 10,000 for that device. No? So we are reducing the cost. So we press. Our assistants will go on pressing the patient for like half an hour, 40 minutes. Okay, thank you.
Thank you.
Connector. കണക്ടർ എവിടെ അമ്മയ്ക്ക് ഇതിന്റെ കണക്ടർ
Just a quote.
So thank you, Sanjith and Vivek, for presenting something about ischemic stroke. I'm just presenting what we are doing here in KMF. Now, I'm a neurosurgeon, okay? And neurosurgeons don't treat stroke, okay? At least in CMC Vellore. You have a stroke, the neurology guys will do it. If the stroke has edema and needs decompressive craniectomy, they'll call us at 12 o'clock in the night. Okay. So, but here coming to a small place like Kotagiri, for even if that's a varicose vein or a stroke, they come to the Narambu doctor. So, I felt that, stroke needs to be treated, but I was very hesitant to go into thrombolysis because my feeling was that mild strokes anyway, they will improve on their own. Why do thrombectomy, thrombolysis and give complications? Severe stroke anyway, they're not going to do well. So because that was something that was initially the idea behind thrombolysis, that maybe it's really not effective. Then Dr. Jayaraj Pandian, who's a very eminent neurologist, he's in CMC Ludhiana. Especially in stroke, he's a very well-known person. Am I right? Yeah. So he had a program where he was training people in peripheral hospitals, training the team to set up a stroke unit, starting from thrombolysis to stroke management to post-stroke management, rehabilitation, long-term management. So he selected our hospital also for the program, and we got our entire staff, doctors, nurses, physiotherapists, speech therapists. We got all of us trained by the Dr. Jayaraj Pandian and his team, and we set up the stroke unit in August, and we had our first patient, I think in August or September, we had our first patient. So in 1 year, what we have done, I'll just present, and yeah, so this is just a 1 year experience. Okay. So the components of stroke care are: one, early detection and hyperacute care. That means when they come immediately after a stroke. Second is the treatment in the stroke unit, which is BP control, sugar control, tenecteplase, comorbidities. Then stroke prevention strategies. That's to, medications. He talked about interventions and all that. And finally, long-term stroke management through rehabilitation. What are we doing here in Kotagiri? For acute strokes, or what I call hyperacute strokes, patient comes, if they come within the first 4 hours, let's say, okay, this is what we do. When they come to the casualty, as soon as they come to the casualty, the vitals are taken, BP, heart rate, saturation, GRBS. We do an ECG for all patients. We do the NIHSS score and the MRS score, okay? Immediately, if they are eligible, if they are within the window period, or even if they are not within the window period, we send them for a CT scan. The we have the CT scan in KMF for the last 2 years. Before the CT scan, if a patient came with stroke, we would send them to Kunnur. They'll go, they get the CT scan done, and by the time they come, 3 hours just to get a report. Okay, forget about window period and all that. So it's been a huge blessing that we have a CT scan now. Within 15 to 20 minutes, I'm able to get a diagnosis. CT scan will tell me, is there hemorrhage or is there no hemorrhage? Okay. Most CT scans in a hyperacute stroke, first 2 hours, 3 hours, the CT scan is normal. But clinically, patient has stroke, that means it's an ischemic stroke. No hemorrhage, that means he can be thrombolized. So if it is a hemorrhagic stroke, we treat as a hemorrhagic stroke. If there's no hemorrhage, we see if they're eligible for thrombolysis. And if they're eligible for thrombolysis, basically it's very simple. We try not to go above the age of 70. No recent MI, no recent surgery, no recent injury of any kind, no bleeding tendencies, and not on anticoagulation. If they fulfill this criteria, we take the consent for thrombolysis. We shift the patient to the stroke unit. You're welcome to come to KMF. I'll show you the stroke unit and what we do. And once the patient goes into the stroke unit, if the consent is given, if the vitals are stable, BP is stable, patient's otherwise okay, we give off the tenecteplase. We give 0.2 to 0.25 mg per kg tenecteplase. It's a single push, like Dr. Sanjith said. And then we monitor the patient hourly, BP and pulse rate, even 15 minutes, every 15 minutes. It's a continuous monitoring for the first 6 to 8 hours. And usually after 16 to 24 hours, usually on the next day, I do a repeat CT scan to see if there is any complication like hemorrhage. So that's what we do. Now, in the stroke unit, after the repeat scan is done, if the repeat scan shows hemorrhage, we treat it accordingly. If there is no hemorrhage and vitals are stable, usually the next day itself, we shift from the stroke unit to the ward. And once they're in the ward, they continue to be monitored. And in the ward, we do a swallowing assessment, which is very, very important. I didn't know this, but I think it is very important because if the swallowing is not good for whatever reason, we don't start feeds. We put an NG tube. Patients don't like NG tube. Patient says, "Sir, the tube podadinga," but they need. I think it can save a life. It can save a life. So swallowing assessment is very important. We get a physiotherapist involved. We start the physiotherapy immediately. If everything is okay, patient has improved well and vitals are stable, within 48 hours, I usually keep for 48 hours and then discharge the patient. If they are not stable or they need some more physiotherapy, we keep them for 4-5 days. What we do is some patients who need a lot of physiotherapy, we keep for 4-5 days, we discharge them, and then we readmit them only for physiotherapy, and we usually do it free of charge. So they stay for 5 days, 10 days, just for physiotherapy. And because it's free, people are willing to stay. But at least they benefit from that. So that's also something that we do. This is just a list of, in the last 1 year, we have done about 17 cases, which is about 1 or 2 cases a month we get. We had 1 case today. And if you look at the number of cases, most of them are under 65 years of age. There are 2 or 3 patients who are more than 70. 1 patient who was 86 years old. We said we don't want to do, but that was a nurse's mother. She said, please give. So we gave, but the patient didn't do well. One thing I've noticed is that after the first 3 or 4 cases, I was a convert. I realized that this actually works and patients actually get better. And generally, we see that within the first 1 hour, in some patients, first 15-20 minutes itself, they start moving their hands. And within 1 hour, most patients improve within 1 hour. Maximum I've seen is up to 3 hours for improvement to happen. And once the improvement happens, generally not much more happens in the first 48 hours. Some people continue to improve for 1 or 2 months even. So in the 3rd month, they're almost normal. Okay. So I'm quite convinced now, as a skeptic, I'm quite convinced that thrombolysis actually helps. If they come within the window period and we select the patients correctly, it actually helps. And it was very sad. People, especially the tribal pockets from that Solurmatam, that area. I had one young man, especially people who are young, they do well. 45, 50-year-old people. Young man came one day, 24 hours after a stroke, and we couldn't do anything for him. He was left hemiplegic, and he was the only breadwinner of that family. So I would like more people to be aware that we are providing this service. We cannot save everybody. So what I tell patients is that, according to standard studies, out of 100, about 33% do excellently. Okay, 1/3 of them do excellently. They come almost normal. Another 1/3, 33%, they improve significantly, but not to normal. Another 30 to 33%, not much happens. They may even worsen or they remain the same. And that's what I tell the patients also. So this is just what we have seen in the last 1 year. We have done 17 cases. Like I was saying, the average duration of stroke at presentation in KMF is actually less than 2 hours. So which means people are coming within 2 hours, and our average was 1.5 hours. Okay, and average time between stroke, the actual stroke happening, to the tenecteplase being given is around 2 hours. That's my experience over the last 1 year. And door to needle time, that means when the patient comes to the hospital to the time when the injection is given. I looked at the data only in the last 2 weeks. Most patients within 1 hour, we are able to, when the patient comes into KMF, within 1 hour, we are able to give the thrombolysis. Some patients within half an hour itself, usually the delay is, நான் அப்பா கிட்ட பேசுறேன், பையன் கிட்ட பேசுறேன், பேசிட்டு சொல்றேன். That's where the usual delay happens. But if they give the consent quickly, and nowadays they're giving consent a little faster, because I think they realize that it is being done. If the consent is given quickly, within 45 minutes, the patient can be thrombolized. And because it's tenecteplase, it's just a single push. And the people who improve, they improve within 1 hour itself. They start walking and talking. People who come aphasic, cannot talk, 1 hour later, they are talking. It's very gratifying to see that. Not everybody goes like that. So we do something known as the MRS scale. Just for you to understand, in case you're not familiar, MRS grades are 0 to 6. 1 and 2 is no significant disability. 3, they have some disability, but they're able to walk unassisted. 4, moderately severe, they need some assistance for walking. 5 is bad, severe disability, and bedridden, incontinent, and 6 is dead. Just in case you're not familiar with this is a good ranking scale to see how much the patient is improving. What we have seen is that most patients, when they come, out of the 16 of the patients, their MRS score was 5. That means they were bedridden and could not walk, could not do anything by themselves. At the end of 3 months, out of the 17, 7 patients had excellent outcome. That means if you see them, they're almost like normal. In fact, I had one patient, he improved well, and we were discharging him. So just before discharge, I just wanted to go and talk to the patient and say what to do and all that. Ward pona patient kano. On the way to the ward, there's one waiting area. One man was standing in one jacket. I thought he came for some casualty thing. I went to the ward, patient is not there. Then I asked the nurse, where is the patient? Sir, anga nikkaru. I could not even say that he was a patient, So the people who improve really well, and it's worth, taking that risk. Out of 17, 5 patients had moderate outcome, which means they improved, but not completely. And 5 patients, which did not do well, and some of them died. And so who are the people who did not do well? They were generally people who were 70 and above, and people who had large strokes, large artery infarcts. 2 of these were malignant MCA infarcts, and they passed away. Yeah. So on the whole, I think we've had fairly good outcomes by the grace of God, and I think we are doing a service. And I just want more people to be make use of this service. Now, apart from that, we do rehabilitation, intensive rehabilitation in the hospital. In fact, we admit patients sometimes only for rehabilitation. We say, don't pay anything, just come and just do rehab, because it makes a big difference. If a bedridden person can at least stand and go to the toilet, it's a big win. So rehabilitation is something that we do, and on top of also apart from that, our palliative and home care group goes to the houses of people who cannot come to the hospital, and we do what we can. Now, some of them have huge bed sores, some of them need a catheter change, so that's also a part of our stroke care. And I also think that stroke research is also a part of stroke care, and we have just started a community-based stroke prevalence study for the entire entire Kotagiri block and part of Kunnur and Ooty. It is along with the government, we are doing the stroke research as well. Just a few pictures. This is our stroke unit. We have 2 beds. This is some of the patients undergoing physiotherapy after the stroke, both limb physiotherapy, gait training, physiotherapy. This is the home-based care for chronic stroke, where they go to the home and take care of patients who need some kind of care. These are some of the patients who did well. That little family on the left side was the first patient that we had. He came in completely bedridden. He went back walking. Even his hand did not improve well, but he was a driver. 1 month later, I told him, don't drive. 1 month later, I asked him, what are you doing? Wife is saying, sir, நான் எவ்வளவோ சொல்லி பார்த்தேன், அவர் டிரைவிங் பண்ணாம இருக்க மாட்டாரு. With a weak hand, he's driving. TL எடுக்கிற வண்டி. Okay, so these are the people. This picture on the right is actually a hemorrhagic stroke. He came because he was left for dead in Coimbatore, saying nothing more can be done, and they came here saying, can you do anything? I said, we'll see what we can do. But thankfully, he went walking out of the hospital after about more than a month. I think more than a month he was there. So yes, I'll just end with some pictures. Sorry. Just some videos. I'll end with that. So this is a patient who came. I'm asking her, Kai Tukku. So she has a right-sided weakness in the upper limb. One leg she's able to lift well. Just grade 1 to grade 2 power in the lower limb. I'm asking him to tell her name. She has expressive aphasia. She cannot talk. She's comprehending. She has pure motor aphasia. Okay. So that was the thing, and this is how she was 2 days later. This is the same lady at discharge 48 hours later. No arm drift even when she was discharged. I'm asking her to move her legs. Leg has also improved too. She was just a tea picker from far away, I think from Sholurmattam, that area. And she was also lost to follow up after 1 month. But I'm just happy that we were able to make her walk and go back to work. Now I'm asking for a name, and she's telling her name. So even the aphasia, improved. The facial paralysis also improved. Okay, this is another man who came, not so severe weakness. See, he has a facial UMN facial paralysis. upper motor neuron facial paresis. I'm checking whether it's a lower motor neuron facial paresis. It's not there. I'm asking him to, if you notice his left hand, it is slowly drifting down. Not a dense weakness, not as bad as that lady, but definitely a left-sided weakness is there. And the leg also, right leg, he's able to lift it. Left leg, when I ask him to lift, he's not able to sustain the lift. So his leg is slowly again drifting down. Okay, he didn't have any aphasia, and this is how he was just one day later. Asking him to lift both his hands, no drift at all. He did. This is one person who did very well, and this is one person who has been faithfully coming for follow-up. Leg also completely, he improved. Facial paresis did not improve completely, but 3 months later, that has also become almost normal. So yeah, so thank you. So yeah, so now we have started the telestroke program as well with Dr. Vivek Nambiar's team, where if a patient comes at any time, we transmit the images to Dr. Vivek's team so that any guidance or for stroke can also be done real time. Anytime is what he has promised. So that's another advance that we have made recently. We just inaugurated it today. Thank you. Any questions? Anything you want to ask? Okay. Dr. Sanjith came prepared for one more talk on hemorrhagic stroke. Are you okay with it, or shall we have it? Yes. It's okay. You can do it briefly also.
I'll be very brief.
I think he will need his.
I think you can either have the talk or question and answers. Whichever you want.
More interactive. Sir, I'll get the mic.
Downloaded that, I think, no? Intracranial hemorrhage. So we'll have a case scenario here. A 60-year-old man who's a known hypertensive has come with acute weakness on the left side, and he has come within 3 hours. Blood pressure is 200 by 120, and his GCS is little bit on the lower side. So, and you've done a scan, and this is the scan, and you are examining the patient. So the usual questions you will be asked by the family will be, is the son is asking you, is my father serious? Can you give? Then you tell the family that he is having a bleed. Then they are asking you whether you can give any medication to stop this bleed. Then Also, they're asking you whether you can do any surgery to save him. So these are the usual questions you will be asked. So in the next slides, we'll see how we can answer these three questions. So intracranial hemorrhage is also called spontaneous ICH or non-traumatic ICH or primary ICH, where there is a focal collection of blood in the brain parenchyma, which can be also in the ventricular system, which is not a result of a trauma. So that's the main thing here. So up to 20% of all the strokes you see can be hemorrhagic strokes. So if you look at the list, there is a huge list of causes for intracranial hemorrhage. But the main two things which we commonly see is hypertensive bleed, which is most commonly seen in India. If you go to the West, also you will see a lot of amyloid angiopathy. So these are the two most common causes of intracerebral hemorrhage. Now also with lot of drug abuse, this last thing is also becoming more and more common. So, so how to differentiate between these two? In a hypertensive bleed, this will be the classical site in the putamen, whereas if you see a lobar hemorrhage, it is more likely to be a amyloid angiopathy bleed. Also, what we should know is there are some medications which can we have to be careful, like patient on aspirin or clopidogrel or any other antiplatelet agents or oral anticoagulants or even serotonin reuptake inhibitors and even statins with very low LDL. All this can actually precipitate bleed in a patient who has very uncontrolled hypertension. So it's a combination which causes a higher bleeding risk. So again, coming to the pathophysiology, when a patient comes with a bleed, he goes through 3 stages, and you might be seeing the patient in one of these 3 stages to take whatever appropriate action required. So again, coming to this diagram, so we have a bleed. In the first few hours, this bleed can expand. Okay, so this is the stage 1 where you have a hematoma which is expanding, and then it will become stable. Okay, so this will immediately start causing injury to the brain because there is sudden mass effect in the brain, and there will be a raised intracranial pressure. So this usually the hematoma expansion occurs in the up to first 6 hours. Okay, so suppose you are seeing a patient at 1 hour with a bleed, you can potentially again worsen up to first 6 hours. The next stage is called the stage of perihematoma edema. So here what happens is around the bleed, there will be edema formation like in any other ischemic stroke. Here also we can have lot of mass effect. This will again increase your brain mass effect and cause raise in ICP. So if you look at this scan, you can see that this patient has done serial scans. You can see actually the bleed is in fact the amount of blood is coming down, but the edema is actually increasing. So this is an important thing to know. And the third stage is a stage of resolution, where the RBCs get destroyed. But this also can cause injury because once the red blood cells are getting lysed, it will release a lot of neurotoxins, and which can affect the cells in that region. The cells in that region will take up these toxins and cause destructive effect. So this is the third stage. So the first question is my patient serious? So what basically we have to tell them is there is a 40% mortality in a patient with the intracranial hemorrhage, and even if they survive, there is up to 60% of them can have disability. So this is the first thing you should be telling the family. Then if you want to further refine your answer, you can use something called the ICH score. I think all of us should be knowing this. You just need a plain CT scan to calculate this ICH score. So you can see here, you have to have a GCS. You can calculate the volume of blood easily by doing what you call as a ABCD by 2 score. And then you have to look at whether the blood has gone into the ventricles also, and then whether the bleed has gone into the infratentorial compartment, and also the patient's age. So these are simple score to do. So higher the score, the more it predicts the 30-day mortality of that given patient. So this is the way how you can calculate your volume of the bleed using the ABC by 2 score. Okay, so per patient comes with a ICS score of 5 means there is 100% mortality at 30 days. You have to tell the family, like, it's very unlikely that this patient is going to survive. Also, what you should know is the hematoma can expand in the first 6 hours, and then you can have your perihematomal edema. So don't do the score in very early. Like, if you do the score very early, you might get a low score. Okay, so suppose you do the scoring at 3 hours, you might score 0 mortality, 70% chance of being independent. You can give them false hopes. Okay, but same patient, as I told you, the hematoma can expand up to first 6 hours. So just wait and then do the scoring only after the at least 24 to 48 hours. Then only you can prognosticate. So any patient comes with a hemorrhagic stroke, tell the family that we cannot tell anything for the next 48 hours because there is a chance that patient can worsen up to 48 hours. At 48 hours, you can do this ICH score and then you can further prognosticate. Any medicines to stop the bleeding is the next question. So if you look at the hemostatic therapies, you can give some medication. The main thing here is acute BP lowering. Like in ischemic stroke, you should not lower BP. In hemorrhagic stroke, you have to bring down the BP. Earlier, there was a medicine called factor, I think it was called Neuro, but we cannot use this drug any longer because the studies have shown it to have a level A evidence of harm. So if you give this drug, there's a high chance the patient can have myocardial infarction or a ischemic stroke. So you can get sued if you use this drug other than in clinical trials. So no 7. So this is harmful. Tranexamic acid has been tried in many trials, but it didn't show benefit, but it was not harmful. So there are trials still going on looking at tranexamic acid. What about suppose a patient has taken antiplatelets and has now come with the bleed? Is there any role of giving platelet transfusion? So this also have been looked at, and in fact, the patients who received platelet transfusion, they had a higher mortality. So there is again no point in giving platelet transfusion for patients who come with bleed while on antiplatelet agents. What about warfarin-related bleed? It's a common scenario. Patient has rheumatic heart disease, is on warfarin, now has come with the bleed. So how can you treat this patient? So here, the main thing is, instead of expanding up to 6 hours, these patients, the hematoma can keep on expanding up to 12 hours minimum. So we have a window there to do something. So here we have to replace, so warfarin depletes the vitamin K dependent factors. So we have to replace these factors as early as possible so we can at least stop the expansion of the hematoma. So how can we give vitamin K dependent factors? So first thing is you have to give vitamin K injection. Okay. So we have these 3 things we can give: FFP, prothrombin complex concentrate, or vitamin K. So all patients, while they have bleeding while on warfarin, we have to give vitamin K, and that too we have to give it IV, not IM. So here the main problem is if you give vitamin K, the onset of action itself will take around 4 hours to start working, and the full effect is only achieved at 24 hours. So we cannot wait till then because we have a hematoma which is expanding. So other thing we can do is to replace the factors, which is the vitamin K dependent factors 2, 7, 9, and 10, by either giving fresh frozen plasma, or now we have drug called prothrombin complex concentrate. So if you look at fresh frozen plasma versus prothrombin complex concentrate, first the FFP, that is, you have to, it is a blood product. So you have to first, if there is a blood bank, you have to get it from the blood bank, thaw it, then slowly infuse it, and it's a high volume thing. Whereas this the prothrombin complex concentrate is just it comes in a small vial. You just have to reconstitute it and give it off immediately. So the time is important here. So you can easily give it within 15 minutes, whereas in FFP you have to wait for the product to come and then thaw it and give it. It will take longer time. So if you have the luxury of giving prothrombin complex concentrate, that will be your drug of choice here. What about now people have started using a lot more apixaban, dabigatran or rivaroxaban. So what about those patients who come with bleed while on these agents? So all these agents have now got specific antidotes. Like if you're somebody comes with dabigatran and has a bleed, you can give a specific antidote called idaruximab. Or if you are on either rivaroxaban or apixaban, you have again antidotes for that. But unfortunately, this is costly and not freely available. So again, if you have the next best thing you can do is to give your 4-factor prothrombin complex concentrate. Acute blood pressure lowering is one thing which all of us can do. Doesn't cost any money for that. So the BP has to be assessed very carefully every 15 minutes, and then you have to bring it down. If the BP systolic is 150 to 220, you have to bring it down to 140, and then in the first 1 hour. So that is the main thing, and then maintain it at below 140 systolic. But if your systolic BP is very high, more than 220, then you should not bring it down to 140. In the first 1 hour, just bring it down to 220, and then gradually bring it down to between 140 to 160. So this is the recommendation for blood pressure lowering, which we have to do for all patients with hemorrhagic stroke, especially hypertensive bleeds. Okay, so what drugs can you use? Again, you can use short-acting beta blockers or calcium channel blockers here. The drugs to be avoided is nitrates. So nitrates again can cause cerebral vasodilatation and again add on to your raised ICP. Also, don't use thiazide diuretics because it can cause hyponatremia, which can worsen your cerebral edema. So these are the drugs to be avoided. And the patient is on oral hypertensive, which he has missed or something, immediately start his regular medications while you're doing all these things. The last thing is, can you do surgery to save him? So this is something which you should know. So we can divide the patients of ICH into 3 groups. One is supratentorial hemorrhage, so and infratentorial hemorrhage, and those with intraventricular bleed. So if a patient comes with infratentorial hemorrhage, so like this, who has a large cerebellar hematoma, which is more than 3 centimeters in diameter, and which is, especially if it is causing any compression on the brainstem or hydrocephalus, definitely the surgical intervention is going to benefit this patient. So no question of not having surgery for such patients. Just refer him straight for surgery. What about this patient? You can see that there is a bleed in the pons. In this patient, there is no role for surgery. It's only conservative treatment. Patient with superficial hemorrhage like this, which is close to the surface. So what the studies have shown is you can do surgery in these patients if it is less than 1 centimeter from the surface, that too within 48 hours from the onset, provided there is no intraventricular extension and the age is not too much. So this is one group of patients who can benefit with surgery. Now we have deep-seated intracranial hemorrhage like this. Earlier, we never used to give them any surgical options, but now there are treatment where you can do guided procedures. You can do guided procedures and take the blood from that specific area, and patients can benefit. Intraventricular hemorrhage, these are patients who have higher mortality because the blood has gone into the ventricles. So the problem here is the blood in the ventricles will later on prevent the CSF flow, and they can have hydrocephalus. Okay, so here you have to do what you call as a external ventricular drain. So you have to put a drain and take off the CSF and the blood in the first few days. And also there are newer studies which are even looking at putting some lytic agents into the brain so there is no adhesions forming which can to prevent the secondary hydrocephalus. So basically this is a quick talk. So hope we can answer these three questions when a patient comes to you with hemorrhagic stroke. Thank you.
Thank you. This is the time for questions. Any questions, please feel free to ask.
Hemorrhagic stroke. How long do you do anticonvulsants and then?
Yeah, so hemorrhagic stroke, we give anticonvulsants you don't need to give, if it's a deep-seated hemorrhage, there's no role for anticonvulsant. If it is a cortical this thing, then you'll have to give anticonvulsants usually for 6 months. So what we can do is at the end of 6 months, you repeat a scan and then see whether there is a large cortical scar. If there is a large cortical scar, that can be an indication for continuing the anticonvulsant. So that's especially if the patient had a seizure in the beginning, then we have to continue if there is a large cortical scar.
Most hypertensive bleeds, and hypertension is the most common cause of ICH. And most hypertensive bleeds are capsuloganglionic. That means they are deep in the basal ganglia and the lentiform nucleus. They are not cortical. So even if it's a large hemorrhage, really no use giving anticonvulsants. But things that are peripheral in the cortex.
And the problem is once you start anti-epileptics, unnecessarily the burden is on the following of doctor to reduce it. The problem is not starting. If you unnecessarily start the anti-epileptic medication, just like whenever the patient comes, sometimes there is a practice that they give Levipil load and load. The problem is the patient will be continuing on Levipil, and patient will miss a dose and they can develop withdrawal seizures. And also the physician who is continuing to follow up the patient cannot stop the medicine. So there is a risk always patient there. So that is a very tricky thing. Unless needed, we don't want to give
And also cerebellar hemorrhages.
Yeah, no need. It's okay.
So regarding this anticoagulant, that antidotes, there many of them are available. We have ready-made factor, 4-factor PCC available readily in the market, and we have.
Is it expensive?
Yeah, there are two brands. One is called Prothrome. Second is called Octaplex. So you have to give it according to the body weight. So it will come to, it's a costly business, it will come to around 1.23 lakhs. But if you compare it with fresh frozen plasma, there are studies which have shown that there has been cost benefit studies which shown that this is, if you look at long term, this is better.
In my experience, if you give a PCC complex, you give 2 ampules of vitamin K and you give PCC complex 1,200 units or 1,500 units. The INR is next 1 hour, it is 1.5. That is instantaneous. And similarly, the antidotes for the NOACs, they are also extremely good. In 2016, I have reported a case also where we have thrombolyzed a patient while on Navigator. So reversed it with Tocilizumab instantaneously. But if you use the original brand, they are giving the drug free. But other brands, they are not giving. You use 70,000.
While shifting, before the CT being done, any medications can be given?
For hemorrhagic stroke?
No, we don't know. Before CT.
Yeah. So that's a
Before
good
CT.
question.
Yeah, I think while shifting, things can be done is one is just quickly do a RBS and then blood pressure and take the history. I think that time should be spent talking to the relatives, detailed history, what drug the patient was taking, whether we had anything in the past. I think that will give us more information to treat the patient, whether it's an ischemic stroke or a hemorrhagic stroke better.
Sir, this question was asked by the community and they have done several trials on this. They tried magnesium, they tried citicoline, they tried
Cooling.
things.
They tried cooling.
They tried cooling of the brain, but none of them worked really well. But I think what we can do practically,
Best thing to shift.
I think the blood pressure is so high.
I would say keep the blood pressure Yeah, makes it about 220. Try to bring it down a little bit. One thing is very clear: no role for steroids. Dexamethasone steroids don't help.
And
Mannitol, okay, it may help, may not help, but because even mannitol, let me tell you, when you have a hemorrhage, even if it's a injury-related hemorrhage, first the maximum edema is between 24 to 48 hours. Okay, so even if you delay mannitol a little bit, it's not going to harm the patient. That's what I'm trying to tell you. So the edema increases after 24 to 48 hours, reaches its peak by about 48 to 72 hours, and then comes down. So by actually delaying mannitol, you may be giving mannitol at the time when it's reaching the peak. So giving mannitol also may not help. Anticonvulsants, if the patient is somewhere very far away and will take a long time, no harm in giving one dose of anticonvulsant. You never know. At least you may be able to prevent a seizure. That's all that I will say. But yeah, that's.
But there's no data.
There's no data. There's no data. I'm just saying.
There's something called anticonvulsants. It can do harm. Actually, there are some anticonvulsants. They can post-stroke recovery need something called brain plasticity. So some of these anticonvulsants can reduce the brain's plasticity. So that's why you should avoid it as much as possible.
So you're telling other causes of stroke like microvascular circulation, thrombolysis have any effect on it?
Yeah, so even if it's a small vessel disease, when a patient comes in the acute setting, you can thrombolyze if there is a deficit. So there's no harm. Suppose I'm giving you, all of you sitting here, tender place or alto place. All of us are getting today. Nothing is going to happen to any of us unless we go and fall somewhere. So the half-life is very small, short. It's a short half-life drug, and there's no harm in giving it even to a stroke mimic. Suppose you are suspecting it's a stroke, like you can still give them the benefit of doubt and thrombolyze. So it's a safe drug in that case.
There's no other doubts. I think we'll close. Thank you. Thank you for patiently, listening, and I hope it has been useful for you.
I think we were mentioning about Dr. Jairaj Pandya. I think all of us should be very proud because he's from Tirunelveli, Tamil Nadu, and he's going to be the next president of the World Stroke Organization. So he'll be not only the first person from India, he'll be the first person from Asia to hold this post. So I think very appreciated.
So end of the day, what we have done is we converted a knife-loving Tony to a pen-loving Tony. And it has benefited the town so much. It has benefited the town so much. And before referring a patient to what we should do is make a few scratches in the sole and the abdomen, which means that you have done a good clinical examination. The neurologist will be impressed before you refer.
I just want to, this is a very important thing. Because now there are a lot of legal, because we are also seeing in CMC, patient not getting referred in time, then later on the family is suing and all that. So I think if you are referring, the best thing is on the paper, you just write referred to this particular place, wherever you want to refer, put the time, referred time, and has been told immediately to go. So that's the document that after that you are safe. So I think that's very, very important.
So the smaller the towns, the smaller the penumbra always. We were able to achieve much here. Yesterday when Jason told us that we'll be on YouTube, the first thing my wife did was ask me to dye my hair. Nambiar is always has a different meaning in Tamil Nadu, sir, but today you are a hero. Today you are a hero.
Very
KMF when we, one day it was very busy and some 3-4 labor patients were there. We pulled out a table from the office, made a sawed a circular hole in the table and used as a labor table. But now CT, thrombolysis. Every day, many times I create situations to go to KMF just to admire what has happened, how kind God is, and that place is really the dream coming true. Today we are really honored to have Dr. Subramaniam with us because he left the town long back. He served as a surgeon. He is with us today. So I request him to give away the mementos to the. Can you come? Please come here. Dr. Tony. We thank the sponsors for giving us a very academic, entertaining evening. We thank the Neuro for the Sanjith dinner that's waiting for us. Thank each and every one of you for sparing this evening. I think you'll be more than happy now after the meeting. Thank you. And I request the sponsors to say a few words.
Praise the Lord. Thank you for this wonderful evening. My name is William Jaiba. I'm working as a zonal manager in this MQT, that's the Connect Case division we are promoting. Thank you for supporting. Daily, I'm having our own rest of Tamil Nadu I'm covering. I'm having 6-7 key account managers I'm having. They call full RHS. Thanks to the doctors. For Anja life save daily license same Gopi Sundar. And thanks to KMF Hospital, Dr. Tony Bergam and Jason Thomas. They'll be rate discount we are ready to give. We can save the life. And thanks to the wonderful speech of Sanjith Arun sir and Vivek Nambiar sir. Thank you so much. And all the delegates, the 2 of us patients are useful definitely. We will get the guidelines, everything. All the delegates and all the doctors. Thank you so much. Thank you.
Yes, sir.
Thank you.
Thank you, sir.
Thank you for all the others.
Thanks, sir.